everyone, welcome back to my channel. This is Aseel and I'll be talking about IV fluids. One of the most common things that residents and doctors are asked on the wards is, can you please chart some IV fluids? So this lecture will address the things that we need to consider when we chart IV fluids and what type of fluids we should think about. The questions that we need to ask ourselves when we get asked to chart IV fluids is, why does a patient need IV fluids? What's their reason for this admission? What their fluid status is? Are they nil by mouth, and what's the cause for them being nil by mouth? Their oral intake, their blood sugar level and ketones, their kidney function, liver function, fluid restriction, and if they have heart failure. So all those questions are things that we need to consider before charting IV fluids. So the most common fluids that we chart on the wards are normal saline and lactated ringers. This table shows the electrolytes present in both and what is present in the human plasma. As you can see that the lactated ringers resembles the human plasma more than normal saline does. And in this lecture, I'll advocate for more use of lactated ringers, and I'll tell you why. So there are two trials that have proven that lactated ringers may be superior to normal saline in some cases. One of them is the SALTED trial, which followed up patients who were admitted to a non-intensive care unit area, and it showed that the patients who received balanced crystalloids had significantly lower rate of adverse major kidney events in 30 days. They also had lower chloride and higher bicarbonate concentrations. The second trial is the SMART trial, which followed patients who were admitted to the intensive care unit, and it showed a significant decrease in major adverse kidney events within 30 days for balanced crystalloids versus normal saline. There was also an insignificant decrease in in-hospital mortality, and the balanced crystalloid group showed lower incidence of hyperchloremia and lower incidence of plasma bicarbonate concentrations falling below 20 when compared to normal saline. Patients with a diagnosis of sepsis had lower incidence of 30-day mortality in the balanced crystalloid versus the normal saline group. And 1 in every 94 admitted to the ICU and treated with the balanced crystalloid instead of normal saline may prevent the need for new renal replacement therapy, persistent renal dysfunction, or death when compared to normal saline. So what we get from that is that both non-critically ill and critically ill patients who received balanced crystalloids were less likely to have renal injury, leading to need for renal replacement therapy or to have persistent renal dysfunction. So now I'm going to discuss some of the myths around lactated ringers. The first one is that lactated ringers should not be used in hyperkalemia. It's actually not true. Lactated ringers is very safe to be used in resuscitation of patients with elevated potassium levels, and that is because the potassium hydrogen shifts that occur as a result of the acidic environment from normal saline infusion may actually worsen potassium levels. And you need to actually infuse very, very large amounts of lactated ringers to actually worsen the hyperkalemia. And the potassium level that is in the lactated ringers resembles what the normal level of potassium should be in the blood. The second myth states that lactated ringers cannot be used in patients with high lactate levels. This is also not true. Lactated ringers has sodium lactate, not lactic acid. Sodium lactate can actually be metabolized in the body and can produce energy, which may be helpful in ischemic conditions and would decrease overall cell death rather than worsening the acidosis. And to re-emphasize this again, lactated ringer is a more of an alkalinizing solution, and normal saline is more of an acidifying solution because it can cause hyperchloremic acidosis. Also, several studies showed that balanced crystalloids are associated with improved outcomes in patients with DKA, dehydration, and pancreatitis. There are some cases when normal saline is actually preferred, and those cases are when we have a traumatic brain injury, when we have hyponatremia, in cases of burns, and in cases when they are mixed with other medications or blood products when one line is available, and in cases of liver dysfunction. So in case of traumatic brain injury, because of the edema that can happen in the brain, and it is preferred to have more of a normal saline where the sodium is higher, which can draw some of the fluids and decrease the edema that's happening in the brain. As for cases of hyponatremia, because normal saline can help with hyponatremia. Burns as well, normal saline is preferred over lactated ringers, and when it's mixed with other medications and or blood products, when there's one line available, because lactated ringers has calcium, and there is a concern about calcium reacting with some other medications or blood products and precipitating in the blood. So it can be used if there are two separate lines, but it is preferred to use normal saline in those cases. And in case of liver dysfunction, and that is because the sodium lactate, which is present in the lactated ringers, and which can be metabolized to energy in the liver. So if we have a liver dysfunction, this sodium lactate can accumulate. So lactated ringers composition is more similar to human plasma than normal saline. Lactated ringers is preferred to normal saline in select ED presentations such as DKA. Lactated ringers will not worsen hyperkalemia, and the acidosis from normal saline may in fact be more detrimental. Lactated ringers does contain sodium lactate but will not contribute to clinically significant worsening of the lactic acidosis. Normal saline is preferred to plasma light in patients with traumatic brain injury. And consider normal saline when mixed with certain medications such as ceftriaxone or blood transfusions to avoid precipitation when only a single IV access site is available. So I'm going to go back to the questions that we asked ourselves in the beginning of this lecture. Why does the patient need IV fluids? So we need to check if the patient needs IV fluids, if they do still need them or not. Maybe they have been given, but now they're good. So we need to check why they are charted IV fluids, what's the reason for this admission, and what their current fluid status is. If they are overloaded, we're not going to chart any more IV fluids, of course, and we might actually need to do something about it. And if they are dehydrated, we might need to chart IV fluids or increase the rate of fluids that they're getting. Nil by mouth and cause for nil by mouth. As we said, if the patient's nil by mouth awaiting surgery, we can give them some 4% dextrose and a fifth normal saline. But if the patient's awaiting a PET scan or fasting test, we can't give them any dextrose. We can only chart some normal saline or lactated ringers, just if in cases of them being dehydrated. Their oral intake, that goes back to nil by mouth and assessing ketosis. If their oral intake is very minimal and the patient is very old and delirious and is not having much, we should consider ketosis, and by that we can check blood sugar level and ketones and decide what type of fluids to put the person on. Blood sugar levels and ketones, we just talked about that. Kidney function, as we have discussed earlier, lactated ringers is actually preferred in kidney dysfunction or kidney injury. And the last thing is liver function. When patient has a liver dysfunction, we might actually try to avoid lactated ringers. Fluid restriction, of course, fluid restriction is very important. We need to follow the patient's fluid restriction. check if they have any heart conditions that are preventing them from having any more fluids. Maybe the day team have charted one bag and they don't want any more, but you get called, are you going to chart IV fluids? So what I need to emphasize from this lecture is try not to chart IV fluids over the phone. Try to be thorough. It's not, although it's a very boring and usual task on the ward, it is actually very important and needs to be thought about. So this is it for this video. Thanks so much for watching, and if you guys have any questions or comments or suggestions for future videos, please leave a comment below. My name is Aseel Ajlouni, and thanks again for watching.